My name is Dr. Gupta. I'm a board-certified anesthesiologist. Uterine fibroid embolization is a very, very effective technique for treatment of fibroids. I have seen the other options for this type of condition, hysterectomies, myomectomies, and I can tell you that the fact that this is done minimally invasively is what is so attractive about this procedure. We have to give a lot less anesthesia than we traditionally give for hysterectomies or myomectomies. Patients do not have the same requirements for blood transfusions or for fluids. Recovery is a lot faster. We offer moderate sedation with minimal pain requirements in general for most patients, rather than what we have to do for the traditional myomectomies and hysterectomies where the incisions are much larger and the procedure is much more intense. I always feel that in the 21st century, if you can avoid major operations, you should, because the body after a major operation is never exactly how nature had intended it to be. So there is a nationwide effort to engage in minimally invasive approaches to medical conditions whenever possible. So because I know that a lot of women struggle with this problem, I think that the minimally invasive nature of this procedure, as well as the decreased need for anesthesia and for fluids and for blood products, which often is the need in hysterectomies and myomectomies, make this a very attractive option for individuals that are suffering from this condition. So the most appropriate type of anesthesia for a uterine fibroid embolization would be moderate sedation. And the way this differs from deep sedation, or what people more likely call general anesthesia, is that I compare moderate sedation to basically being asleep at 2 a.m. in the morning. You're asleep, you're comfortable, but if somebody were to try to wake you up, you would wake up. So the benefits of moderate sedation is that you're never actually on a ventilator. You're always breathing on your own, but you're so sleepy and you're in such a deep sleep that you don't really have any understanding of what is happening around you. You don't hear things, you won't feel things, you're very comfortable. It varies from patient to patient, but in general, these are all medicines that are fast on, fast off. That is to say that whatever amount of time the procedure lasted, you could expect an additional 5 minutes on either end for your anesthesia. Of course, everybody recovers at a different rate, and so that would be the norm. But people that when they do wake up, they feel like they woke up from the best sleep of their life. So as an anesthesiologist, in keeping with the American Society of Anesthesiology standards, I am required to be present during the full course of the anesthesia. In addition, at Viva Eve, we see the patient in the preoperative area before any anesthetic has even been administered. We are the ones that escort the patient to the operating room, and we stay with the patient throughout their anesthesia, and then we transport the patient to the post-operative care unit. So not only will you have an anesthesiologist there with you the entire time, but you'll also have us there before and after. Important to understand, what are the causes of pain? The cause of pain for a uterine fibroid embolization is inflammation. So what we at Viva Eve do is we try to tackle the inflammation. We treat you with anti-inflammatories before the inflammation has a chance to even develop. Therefore, when the procedure is over, the lack of inflammation allows the patient to be comfortable. Because we focus on treating the inflammation and not the pain, which is the right way of dealing with the anesthesia requirements, these patients, when they go home, they are instructed to just take the actual anti-inflammatory pills around the clock before the inflammation develops, so that the patient does not have any pain. We have at Viva Eve a whole spectrum of pain medication that we can administer. Usually we start with the non-opioids, and then for those patients that may develop severe pain or have an allergy, we do use low-dose opioids for that. So we don't treat just one size fits all. Every patient is a little bit different. We tailor our pain management to each patient's needs and medical issues. It varies from patient to patient. A lot of it depends on compliance with taking your anti-inflammatories, and that's what we tell the patients, that do not wait for pain to develop and then take your anti-inflammatories, take your anti-inflammatories around the clock. That being said, the vast majority of the patients tend to be walking around on the very first day, and they are not needing any pain medications after 2 or 3 days. From an anesthesia standpoint, we don't recommend that patients try to operate any heavy machinery or drive the day of their procedure, because there may be some lingering aspects of the anesthesia that is still on board. What we also tell patients is to try to do activity as tolerated. That is to say, do not push yourself too much, but also don't feel that you have to remain bedbound. Try to re-engage in the activities of daily living as you normally would, and that is the best way to recover. Just try not to think of yourself as a patient, but to go about your business. And usually the pain management is usually sufficient to allow them to begin that process. We call every patient 2 days after their procedure to talk to them about how they're feeling. We also go over with them what pain medications they've required, and we reinforce things that they may have missed, such as having to take the anti-inflammatories around the clock and not just when they have pain. And we also give them any advice that we think would help them in light of their unique situation at the time. And it also serves to offer them a resource to ask us any questions.